Hello everybody, welcome to GP Notebook TV. My name is Julie Oliver and today's short video is going to be on NOACs, or as they're now called, DOACs. And these are drugs that have high risk attached to them and we are prescribing more and more. I've been moving away from some of the COVID advice to try and sort of incorporate some of the other guidelines that have come out. And I think this is relevant for both actually, because in the middle of all this COVID crisis, we were asked to look at our warfarin prescribing and to see whether we could switch people onto the less frequently monitored DOAC drugs. And as a consequence of that, I think our prescribing probably has changed and gone up. And it's really important that these drugs, which are used for a whole plethora of different clinical conditions, that we are familiar with them and also familiar when things can go wrong with them. So let's talk a little bit about the drugs. There are 4 of them on the market: rivaroxaban, apixaban, edoxaban, and the one I cannot say, dabigatran. So 4 drugs on the market, and there are now antidotes to 3 of them. It's only the edoxaban that does not have an antidote to it. So if your patients are taking these medications, and remember the risk of bleeding is a problem with these medications, if you are considered that these patients are having bleed, some likely to be GI bleeding, but could be bleeding from anywhere, these patients will need to be admitted and you will need to be administering, well you won't be, but in secondary care they will be administering the IV treatment, antidote treatment and monitoring to get their coagulation back to normal again. So that's the first thing to be aware of. There is now antidotes for 3 out of 4 of them. But for our role within a primary care setting, we need to be familiar with the dosing and the indications for either prevention of atherosclerotic conditions or prevention of thrombotic conditions, or the opposite, the treatment of thrombotic conditions. We need to be familiar with the doses and the regimes that we should be prescribing. And all that's available in the BNF. You need to look it up. You need to be familiar with what the dosing and the regimes are. And also remember that these don't have a license for every thrombotic effect. So prosthetic valves, for instance, you wouldn't be using these medications for. So that's one thing. The next thing to look at is the risk profile of the person that you're prescribing these drugs for, because there is a significant risk of particularly GI bleeding on these medications, and we need to look at the patients that are at high risk to evaluate whether their risk profile is suitable to go on them. So who is at risk of bleeding? So the evidence suggests you're high risk bleeding if you are older, particularly if you're over 80. You're higher risk of bleeding if you have other coexisting comorbidities, particularly liver and kidney disease. And the final thing that you need to be very, very considerate of is the existing medications that these patients are already on. And before I go on to that, don't forget, if you've had one GI bleed or you have a peptic ulcer, you are significantly at risk of another. So let's talk about drugs now. And all of these drugs you'll be familiar with as causing GI bleeds on their own. So particularly all our antiplatelet agents, our aspirins and our clopidogrel-like drugs. Remember, anyone taking NSAIDs also will be at significant risk, and this also includes our COX-2 inhibitors in this group. The third group you've got to be wary of is people taking steroids. So typically would be our prednisones, but you'll have some people on other oral steroid medications. And finally, our last group of people is our SSRI users, which do increase, but not as much, the GI risk bleed profile. So that is your GI risk profile. And that part of your job is to reassess each patient that you're starting on, is their risk profile when they're going on. Now remember, you've got your HAS-bleed score, but this is just relevant to patients that we're using our NOACs or DOACs for in treatment of AF. And this will give us a 1-year major bleed risk profile. And you know, the higher the number, the higher the risk, so that will help you decide whether you feel that's risk worth taking or not. And making that decision with your patients is important, and documenting that down in the notes is vital. But that doesn't apply to maybe all the other reasons why we might be prescribing these drugs. And remember, if someone does have a significant GI bleed, this is the reason why you must fill in the yellow card system and report it as an adverse event so that these are monitored centrally. So the last thing I'm talking about now is monitoring, and these patients must have their liver and kidney function checked, and their kidney function is important because kidneys are the main excretors of these drugs, and if your kidney function is declining, so your ability to excrete this drug goes down too, and you end up with toxicity and bleeding problems. So it's not just your eGFR number that you're looking at, you're actually looking at your creatinine clearance, and within your IT systems there will be an automatic calculator that will give you these numbers. eGFR can overestimate the kidney function that's remaining. So remember, look at your creatinine clearance numbers, and there'll be a link below here to the actual document which will take you to a fantastic table which will then advise you on whether you need a dose reduction of these medications or actually if they're completely contraindicated, and that depends on which product you're using and for what clinical reason. So use the link below. You might want to print this document out and make sure that all your prescribers, and particularly if you've got your pharmacists in there doing their regular annual meds management checks, that they've got access to the document so you can be reassessing at least annually, but maybe more frequently, people that have got less good kidney function, and making sure that risk assessment's done on the benefits of these medications versus the risks. So, hope you've got something out of that. This is a complicated, high-risk area, so we should keep on challenging our use of these medications and the mixture of these medications that we use within a polypharmacy regime to say, do they really need to be still on them, and do the risks now outweigh the benefits? So, keep asking those questions when you're using your prescribing and when you're looking at annual medication reviews. Right, take care everybody. Hope you've got something out of that. More videos next week, and link below to the actual document for more information.